Mania has a relatively abrupt onset, whereas the onset of a depressive episode can be more insidious. Nevertheless, depression is still more abrupt in onset in bipolar disorder than in unipolar depressive disorders. Frequency of episodes. A decrease in euthymic intervals is predominantly observed during the first three affective episodes, whereas with unchanging euthymic intervals for the further episodes. Antidepressant use may be associated with more frequent mood episodes. Pattern of episodes. Many patients with bipolar disorder present with a depressive episode and about 40% receive a unipolar diagnosis. These individuals tend to develop a manic episode within 5 years of their first affective episode and have more depressive episodes than patients with true unipolar depression. Polarity of onset may convey prognostic advantages. Individuals with unipolar manic presentations experiencing the best prognosis. There have been suggestions that women experience more depressive episodes than their male counterparts, but the STEP-BD study found no gender difference with respect to the past manic or depressive episodes. Sequences of mood polarity remain relatively constant once established, with those who experience mania followed by depression, then remission, having the better outcome. Poorer prognosis is predicted by the persistence of depressive episodes. Bipolar 2 disorder is associated with high lifetime prevalence of anxiety disorders and tend to follow a chronic course with significantly more minor and major depressive episodes and shorter periods of inter-episode recovery. Overall, patients with bipolar 2 disorder have more effective episodes than those with bipolar 1 disorder. Rapid cycling bipolar disorder, Danner and Feeve 1974 introduced the concept. Prevalence is estimated at 12 to 24% and has been correlated with earlier age of onset, comorbid substance misuse, and greater severity of depressive episodes. Pediatric bipolar disorder, 5 to 6-fold increase in the reported incidence of pediatric bipolar disorder in recent years, especially in USA. It is not clear if this is because of misdiagnosis or greater identification. It seems unlikely that the majority of these individuals will have their diagnosis confirmed on transition to adulthood. A comparable increase in diagnosis in adults has not been observed. Treatment. 30 to 50% of individuals respond to lithium or an anticonvulsant when in the manic phase. The response rate is atypical. The response rate to atypical antipsychotics is similar. In acute bipolar depression, response rates to lithium and anticonvulsants are about 30%, with an exception of lamotrigine, for which response rates are about 50%. Quetiapine appears to have superior efficacy in acute bipolar depression and has been found to lead to remission in about 50% of patients. Non-adherence to medication is relatively common, with only half of the patients reporting good adherence. Those with comorbid personality disorders and more hospital admissions are more likely to stop the medication. Long-term outcome. Bipolar disorder is a lifelong illness. Persistence of depressive symptoms during follow-up appears to predict the poor outcomes. A 40-year-old follow-up of the Jewish cohort found 16% has recovered. Recovery being defined as no episode for the past 5 years, but over 50% were still experiencing recurrent episodes. Comorbid conditions. 65% of patients with bipolar disorder have at least one comorbid psychiatric disorder. It is of note that many of the axis 1 comorbidities are more commonly found in people with bipolar 2 disorders. Alcohol misuse. A lifetime history of alcohol misuse is one of the most common comorbidities occurring in about 46% of people with bipolar 1 disorder. It has been suggested that alcohol may help alleviate early symptoms of mania. Individuals with bipolar disorder are also more likely to drink when in a depressed state than individuals with unipolar depression. A mixed affective state is associated with higher alcohol intake compared with non-mixed states. If alcohol misuse predates the onset of bipolar disorder, outcome appears to be better. Later, due to later illness onset, perhaps suggesting that alcohol misuse causes the emergence of more benign forms of the illness. For those whose alcohol misuse increases following illness onset, prognosis is much worse in terms of both psychopathology and overall outcome. Cannabis use. Cannabis use increases the time spent in an affective state, is associated with rapid cycling, and while the majority of cannabis use remits during hospital admission, it is rapidly reinstated following discharge. Anxiety disorders. Comorbid anxiety disorders are more common in bipolar 2 disorder than bipolar 1 disorder. Bipolar 2 bipolar disorder with high anxiety scores have higher rates of suicide, alcohol misuse, and cyclothymia, and show a poorer response to lithium. Lifetime prevalence of OCD is reported as 21%, although observed to be episodic and often related to mood. Attention deficit hyperactivity disorder. Rates of comorbid ADHD were higher in men than in women, 14.7% versus 5.8%. And the onset of mood disorder in those with ADHD was approximately 5 years earlier than those without. Those with ADHD also had a greater number of other comorbid psychiatric diagnoses, longer duration of relapses, and were more frequently depressed. Eating disorders. Up to 27% of patients with bipolar disorder also have an eating disorder, although most studies suggest it is nearer to 6 to 9%, with 3.7% having bulimia nervosa and further 9 to 18% having binge eating disorder. Access to disorders. Prevalence of access to disorders in bipolar disorder is reported as being as high as 89%, although more conservative estimates are between 25 to 50%. Cluster B personality disorders are most common. No difference in prevalence was found between bipolar 1 and bipolar 2 disorder. Access to disorders are highly relevant as they alter the course of bipolar disorder, convey a worse prognosis, and are associated with higher rates of substance misuse. Physical illness. Bipolar disorder is associated with a number of physical illnesses. Longer prospective studies have reported elevated mortality rates, especially from vascular causes. Blood pressure and glucose regulation. Individuals with bipolar disorder are more likely to smoke and have hypertension. Disturbances in glucose regulation within psychiatric populations have been long observed, and bipolar disorder is no exception. 9% of inpatients were found to have type 2 diabetes mellitus. Obesity. Up to 35% of individuals with bipolar 1 disorder are obese, independent of medication status or the duration over which the medication had been taken. Obesity is associated with a greater number of lifetime depressive and manic episodes, more severe and difficult to treat index affective episodes, and greater likelihood of developing an affective recurrence, particularly a depressive recurrence. Thyroid disease. Thyroid disease is more commonly found in bipolar disorder population, especially in women, and this finding is present in populations that have not received lithium therapy. In bipolar 2 disorder, rates are estimated to be as high as 9%. Migraine. Migraine headaches are more likely to occur in women with bipolar 2 disorder. Males with bipolar disorder who have migraines are more likely to have an earlier onset of illness and higher prevalence of anxiety disorders, whereas females with bipolar disorder who have migraine have higher rates of comorbid medical problems. Pregnancy is an important risk factor for relapse in the course of bipolar disorder. 27% of women with bipolar diagnosis are admitted to the psychiatric care in the first postpartum year. The risk of recurrence during pregnancy was 71%. The majority of these episodes were depressive in nature, and nearly half had occurred within the first trimester. Recurrence were more likely if a woman had discontinued medication, had bipolar 2 disorder, and had previously been treated with mood stabilizers. These results emphasize the need to balance the risk posed by ongoing treatment to the fetus with those of a recurrence of an affective episode. Mortality. People with bipolar disorder have a worse prognosis than the average population with respect to both suicide and medical causes of death. The Zurich cohort reported a 61% higher risk of death, the standard mortality ratio being 1.6, with greater risk of being that of suicide. SMR is 12.28. Those with bipolar depression and those who received long-term psychotropic treatment were less likely to die by suicide than those with unipolar depression. Suicide rates are high in bipolar disorder, SMR 15 in males and 22.4 in females, and suicide tend to occur early in the course of illness. Attempted suicide is common, with 35% reporting a history of suicide attempts on entry to the CBD trial. So the key points, the age of onset is between 15 to 20 years. 40% of individuals are initially diagnosed with bipolar depression. Bipolar 2 disorder is a stable diagnosis, now made more frequently and associated with a chronic course in which depression is usually the predominant plurality. These are my references. Thank you.
Thank you, Dr. Priya. This wonderful presentation. And before doing every therapy, we need to do psychoeducation to the patients. So these are the factors and related to the bipolar disorder, helpful to do the psychoeducation easily. Thank you.
Dr. Sanjeevani, whether you want others to ask any questions?
Yes, sir. If anybody has any questions, please ask them.
Yes, I think it was a good presentation. I have a few comments. First is the references. I think that number of statements have been given, although they are valid, but we should put references wherever possible.
Yes,
also, at the end, I think we should provide a glossary of references. The number of references you have shown is 2. You have taken it from a book. Which book? Can you please show the references slide?
Yeah, yes, sir.
Yeah, so 2 references would not be sufficient for seminar like this. Okay.
Yes.
And if you're taking it from an article or a book, you need to check up with the references given in the book or the article also, and you try to get to the main source of the information.
Yes.
Some of the information that is given, I think, that needs to be, you can say, needs critical appraisal. For example, you said that thyroid disorders are found in people not taking lithium. Okay.
Yes,
so I
sir.
think it would be like they are also found in people not taking lithium. Like lithium does not make a difference. It is not that thyroid disorders are predominantly found or found in people taking lithium. Second is that association of hospital people who are hospitalized have worse prognosis.
Yes, sir.
So it is other way around, like people who have a worse prognosis or who have a severe disorder are more likely to be hospitalized.
Yes,
so it comes around as if we hospitalize the patient and the prognosis will be worse. It is the other way around.
Yes.
If a disorder is severe, then that person is understood. He is more likely to be hospitalized.
Yes.
So I think that you need to read more critically into what is written in the book also, and the references need to be cited properly.
Yes.
That's
Yes. All. Thank you, sir.
Dr. Priya, I think
yes, sir.
few of my comments, like one thing that thyroid disorders, because you said that it is present in 9%.
Yes.
So 9%, whether thyroid disorders, hyperthyroidism is present, hypothyroidism is present.
Yes.
Sorry.
Yes.
That could have been pointed out.
Yes.
This is a very important seminar from context of your exams, the daily patient handling. So course and outcome is a long question. And generally, it's at times it is thrown as a viva question also.
Yes.
So it becomes very important, and maybe we could have gone with more recent Goodwin and Jemison. I think you had shared the reference of Goodwin because he has worked a lot. maybe something of more recent 2021, because
Yes, sir.
last 10 or 11 years, what has happened to the course
Yes.
and outcome, any other recent data. One study which is must is step BD trial.
Yes,
And
sir.
when we're talking about course and prognosis, this prognostification, very importantly, those remission criterias, those relapse criterias, recovery criterias could have been also put
Yes.
here, because that would have updated the knowledge of the audience here.
Yes, sir.
And also uh, uh, like predominant, what is the concept of predominant polarity? So because there can be a huge area, but basically bipolar disorder, the concepts when we talk
Yes,
about.
sir.
But I think you have tried to be crisp, and you have tried to be. One question I have for you, which is the
Yes.
most common cause of medical mortality in bipolar disorders? Medical cause of mortality.
Uh, so, uh, so vascular causes.
Vascular causes. You're right.
Yes, sir.
Very good. And so this thing needs to be read by all the postgraduates and the psychology students also, and this needs to be updated. Maybe next time when we give this seminar to someone, maybe we could update it last 11 years what has happened. So
Yes, sir.
because all the academic practice is supposed to update, we are supposed to know what are the established facts and what are the evolved facts also. And you've
Yes,
done a
sir.
good job. Thank you.
Thank you, sir.
Dr. Sanjeevni, no other comments? Shall we close the meeting? You can just moderate it.